Good morning. My name is Dr. Dan Simon. I'm the Chief Clinical and Scientific Officer of University Hospitals and the President of University Hospitals Cleveland Medical Center. I'm joined today by Dr. Cliff Megerian, the President of University Hospitals and our incoming CEO. Good morning, Cliff.
Thank you, Dr. Simon, Dan.
Great.
Great to see you again.
Great to be here. It's a sunny day, and it's always great to be with our friends and supporters. We're here for another 45 to 50 minutes of interactive questions. We have a lot to cover today, and I think it's probably apropos that it's sunny in Cleveland because we come to you today with a sense of cautious optimism, with a little bit of a yellow light still, and we'll talk about that in a moment. But here are the statistics that I know you're always waiting for. There are 965,000 cases in the United States, and we passed 54,000 deaths in the U.S. this weekend. There are 15,963 cases in Ohio, with 728 deaths overall and 3,178 hospitalizations. The good news is that we have a nice trend down over the last 5 days. The 5-day case average has gone from 448 to 376. Deaths from 34 to 17 in the last 24 hours, hospitalizations from 80 only to 63 in the whole state, and ICU admissions from a 5-day average of 23 down to only 14 in the whole state in the last 24 hours. We've been fairly stable in the health system with somewhere between 62 and 70 or so COVID patients in the whole health system. A few more at the Academic Medical Center at Cleveland Medical Center today, with a little over 20 split between the regular COVID floor and the intensive care unit. So what we're seeing now are some of those criteria that Governor DeWine has put into place regarding when you might start opening up the state, and that is, as we've heard from the CDC and Dr. Fauci, you want to start seeing multiple days of cases going down in number. So that's that cautious optimism. Cliff, what do you have to say so far from the last week till today?
You know, Dan, I think the viewers have had, I think, a lot of opportunity to listen into detailed conversations, both with me and other colleagues, Dr. Salata. But I think one of the messages that I want to get across, if they could leave with one thing, is that we prepared beginning March 15th in this organization, based on the numbers and based on the projections and based on the actuaries who created the models. We created an environment where we were going to be ready to surge to about 350% of our total beds with COVID patients. If you just do the math, we have about 1,700 licensed beds, at least 300% of those, if they were filled with COVID patients, which we got ready for, would have been close to 5,100 COVID patients. As Dr. Simon just mentioned, we're sitting at about 62 patients. So if we, and I totally trust the governor, I trust the leaders, our political leaders, the primary goal for all of us in healthcare with regards to limiting, if you will, access of our patients who are non-COVID patients was predominantly designed to preserve the so-called PPE, the masks, the gowns, for the possibility, and by many measures, the likelihood that we would have been deluged with COVID patients. The fact that hasn't happened, I think, gives a lot of credence to the, if you will, the thoughtfulness of our governor and our state and our leadership here at University Hospitals to institute immediately safe distancing, holding off on non-essential procedures. But I think the good news is, with the data showing at least 5 days of declining patients, that we can begin to now think about opening up our medical system to folks who have had delaying and have been delaying essential medical care, and even some cases non-essential medical care, because we feel pretty good that the PPE stockpile we have is not going to get blown through or eaten through with 5,000 COVID patients. We used to be at 75, we're down at about the 60s, and the numbers are going to keep going down. So we're very optimistic today. We've been working with the governor's office, we've been working with his chief of staff, we've been working with the Ohio Department of Health, and we are hopeful that we will have some, if you will, further clarity beginning today in the next couple of days of how we can begin opening things up with proper care and safety.
Yeah, and I think we'll have a lot of time for questions. We have a whole recovery team that's putting out a playbook for not only how we get back to business, but we're actually committing to helping local businesses and nonprofit organizations. What should guide them in this recovery? So with that, Macy, we want to get right to questions for you.
Well, I feel like the people who are listening have a combination of excitement about returning to normal and some fear. So, the first question is a fair one. If the number of cases increased significantly while we were staying at home for the last 6 weeks, did it really work? And what will happen then when the restrictions are eased? How can we expect those numbers not to go back up?
Well, that's a great question. And I think, Ohio is really the leader of the impact of social and physical distancing on the total burden of cases. You remember that our predictions for surge would be that we would potentially outstrip the capacity within the state. The modeling suggested a physical distancing of about 20% effective. It turns out that if you use triangulation with cell phone towers and mobile phones, residents of Ohio accomplished greater than 60% physical distancing and isolation. And that allowed us to really dampen down on that peak. Now, you are right that the cases continue to increase. And what we're talking about is a decline in the increase. We were doubling every 30 to 40% a month ago. In the last few days, we've been increasing in single digits. What we want to see is at least 14 days in a row of declining cases, where we really are almost now in Ohio. We're certainly not at the stage where we have 3 to 5 days of 0 new cases in the state. We're not there yet, but we're right on target, I think, as the governor is proposing, that whether it's going to be May 1st, or whether it's going to be May 7th or 15th, we do have in our sites now the ability, because of the great work by all of our citizens listening to Dr. Amy Acton and to Governor DeWine, we're in a good position to be able to move forward with that.
Well, as we talk about moving forward safely, of course, the conversation turns to antibody testing. And Michael wants to know if you think that if he thinks he has a mild case, how can you validate this?
Well, I'll start. If someone, clearly right now, what we have the most knowledge about in terms of testing is what's called viral testing, RNA testing. And as Dan may have mentioned in previous broadcasts, we have the latest state-of-the-art viral testing right now with the Abbott Lab procedure, which is able to get testing within about 8 to 9 minutes. And we have 13 of those devices throughout the system. That's the best way to know if you have been infected and you're currently infected. The goal now is to bring online the concept of an antibody test. The antibody test will have and show, maybe even after you are no longer positive with holding the virus, that your body has created the antibodies. And the issue that we have right now nationally is that there's so many different antibody tests that are out in the market that we need, and we're looking for guidance from the CDC and our own infectious disease people to pick the best one that is going to be able to give us the most robust answer as to if someone has now developed immunity. So clearly, to answer the question that the gentleman had, the first step is probably would be some form of a viral test. And then when the antibody tests become available, then that would be very, very important.
Macy, this is a really important question, and I think Cliff and I need to spend a little bit of time on this, because unfortunately, all of us now are receiving emails, and we're hearing things on television related to, you can get a first-generation antibody test that was approved very quickly by the FDA with very little validation data. And these first-generation tests have multiple problems. First of all, one, they cross-react with multiple coronaviruses. You've heard from us before, there are 7 different coronaviruses.
Including the common cold.
Including the common cold. And yes, there is MERS, there is SARS-1, but we want to know, does it detect COVID-19? Is it sensitive and specific for COVID-19? And unfortunately, a lot of the new tests that were approved on very little validation data have very limited sensitivity and specificity, meaning they're wrong both ways.
That's right.
They're false negatives and they're false positives. False positive are bad because it gives you a sense that I had the infection and I may have protective immunity when you don't. False negative isn't good because you want to know that if you did have a prior infection, could I have protected antibodies? We've made a decision here at university hospitals to go with the Abbott platform, which is different than the Abbott rapid viral PCR test, but it's an Abbott antibody test. We've been validating that test all last week. Dr. Christine Schmatzer, who's just an incredible clinical pathologist, and her team have shown that it has a sensitivity and a specificity above 95%. It's the real deal. And Abbott has the capacity to generate 2 million tests a week by the end of April and nearly 30 million by the end of June. That's important because theoretically, every American eventually, as we've learned from South Korea and Singapore and in Germany, everybody is going to need a test. Right now, we're going to prioritize testing to our healthcare workers. So we've made a commitment as an organization to test all of the healthcare workers in university hospitals, which numbers over 28,000, to be able to help us to determine what is their potential immunity status if they've had the infection. How are we going to return to work in higher risk environments? And then after that, we certainly want to make it available to all the high risk groups that we've talked about. So age greater than 65, diabetes, heart disease, lung disease, active cancer treatment, immunosuppression, liver disease. Those are people that we really need to be sure. But there's no question in the US, we still do not have enough testing capacity. It's estimated that we would need 5 times the amount of acute viral testing and antibody testing. And where we face that now when we talk about recovery is our commitment for safe environment is to do a viral PCR test on everybody who's coming for a surgical procedure.
Right.
Before their surgery.
Well, that gets back to how are we going to safely, if you will, open up the access to medical care that heretofore has been kind of, held in abeyance. And so these are the kind of things that, Dan, I think you'd agree with me that there's a lot of surveys that have looked at how the public is going to return to various sectors of our economy. There's the restaurant economy, there's, the hair care economy, but most importantly to us is the healthcare economy. And one of the things that, if you will, that patients are thinking about based on all the surveys that we've had access to is that, number one, patients in terms of when it is time to come back, their number one fear is that somehow they will get the virus in the hospital or the doctor's office. So we are going to do everything we can to have the safest environment possible for that. The second thing that patients say is a concern of theirs is, can they get it by being in a doctor's office or a hospital by simply the doorknobs or the floors? And so what we're working on right now is to present to the community and to you a platform by which we feel that we can attest to the safest environment for when things come back. Because I haven't really said this, but I think we all will understand that we've been now since March 15th holding really thousands, potentially hundreds of thousands of necessary medical interventions and testing, and in fact, some cases surveillance of our patients with a variety of different disorders and diseases. And it's okay for a short period of time, but you'd all in the audience realize that if you keep holding these tests off, let's say mammograms or colonoscopies for months at a time, we are going to start creating a second wave of people who maybe not be injured directly from the coronavirus, but maybe, if you will, a secondary side effect, and if you will, an innocent victim from a lack of intervention and care. So we really are gearing up. We're spending, I would say now twice a day, a command team getting us ready for the re-entry, the so-called re-entry and then reorganization. And part of that is to be able to assure you, whether it's with a combination of at-the-door viral testing, or it's at the door or before your visit, antibody testing with your caregivers, what have you, that is being actively worked on right now, so to present you with a sense of comfort.
Macy, I think the question also gets really at the fundamental issue, and perhaps we could put up the box it in slide that we prepared for you today. Dr. Tom Frieden, who's the former head of the CDC, has really advanced this notion that we're not going to be able to move forward in the pre-vaccine era until we have a very strong contact tracing platform. And that includes this issue of testing, finding, isolating, and quarantining. That's the box it in. Because what we know from experience in Singapore, and now a very interesting article in the New York Times on Sunday, the experience in the Hokkaido prefecture in Japan of what happened where they isolated extremely well. They got the case count really, really low. And then they had a special winter festival,
Right.
Their ski festival, and they saw a big burst of cases. And the way that you have to deal with that is by doing the contact tracing. If you become a COVID positive patient, who are the last people that you were in contact with over the last 48 hours? Every one of them is interviewed. They're either quarantined or tested, or they're given a go-ahead. And what we know by that is it's 6 feet for 5 minutes is a significant contact. And that's the kind of information that you need. The state of Massachusetts has hired 2,400 contact tracers through Partners in Health. And we learned just this weekend in a very interesting article that Partners of Health is trying to help Ohio. Governor DeWine heard about them, and he wants to hire a similar workforce apparently in Ohio to do this contact tracing. So until we have a vaccine, which we can talk about in later questions, we're going to need to know who's been exposed, who's potentially been in contact, and then we're going to have to test. And the good news is University Hospitals is in a great position to be able to do this contact tracing moving forward.
I think, Dan, what you're saying, and you could tell me if you agree with me or not, but, you know, watching all the news shows, talking to people on my street where I live, one of the fundamental questions you hear is, when will we get back to normal? When can I do things as normal? And I think we have to get our arms around the mere fact that until there truly is a vaccine, which can be anywhere from 6 months to a year and a half, when we emerge or we reactivate parts of our society, including healthcare, it's not going to be the normal as we remember it. We're going to liberalize and increase access to many things across the healthcare platform, but it's going to be with new caveats, new rules, if you will, whether it be masking, whether it be testing, whether it be contact tracing, and whether it be certain ways we sit in the waiting rooms that have been completely different from before. This is what we will be doing to help us we just can't wait and hold everything for a long time, because I mentioned earlier, that does have significant consequences as well.
You know, Cliff, I think you nailed it. I think that we're in for, as people say, a new normal.
Yeah.
You know, we're talking about restaurants opening, but if you talk about how does that restaurant open, reduced occupancy, waitresses and servers are going to be wearing masks and gloves, most likely. They talked about silverware being covered, potentially plexiglass dividers in certain parts of the restaurant, a whole new focus on the influence of ventilation, potentially the presence of HEPA filters that filter virus and cause increased air exchange. So it's going to be different. When we go into a bank, you're going to wait outside, just like you do at Heinen's, with little 6-foot marks on the sidewalk. Only a certain number of people are going to be allowed into the bank. And that's going to remain in effect because if you don't, you're going to see a resurgence in cases. And there's no question that universal masking, which we'll get to in a few minutes, is going to be a necessary component of that.
Before we move on, though, from antibodies, would you like to comment on the World Health Organization suggesting that someone might be reinfected with this? We just don't quite know yet about whether or not someone can get sick again.
Yeah, that's a very difficult question to ask, Macy. And, you know, we like Dr. Salata to answer that question for us. But we don't know yet if the antibodies are fully protective. We think so. We think so based on SARS and MERS. So SARS-1 and MERS, that these antibodies that are produced are neutralizing and will offer some immunity. But we don't know how long that immunity will last. And we do not have enough information yet on reinfection to be 100% sure. So I think, you know, I don't know, Cliff, if you want your interpretation of that data.
I do. Some of the earliest reports of reinfection, Maisie, came from some of the countries along the Pacific Rim. And remember, in those days, about a month ago, those were based upon a person who was positive, they test negative, and then they test positive again. Now remember, what we were hearing about and what was being described to us was not at that time an antibody test. It was a viral RNA test. So there's two possibilities that could help us if indeed the goal and our hopes are that the virus doesn't recreate. One was possibility, if it is a RNA test, was that this, remember, taking the actual sample is not completely a simple process. It has to hit the back of the nasopharynx, in some circumstances, sometimes just the nares. So could you have had an inadequate swab on the time that you tested negative? And then secondarily, when the virus is deactivated and it's not live, but it's still there, in other words, it can't replicate, but it's still there, it will still pop off an RNA test, and in other words, say you're positive. So there's a lot of misconceptions. I think what Dan said is the most important. I think what's most important is to correlate those RNA tests with the antibody test and the symptoms of a patient to find out if it really is a reinfection. And I don't think we have those answers right now.
Okay. Lauren wants to talk finances for just a minute. So how quickly do you anticipate restoring furloughed employees and wages? And did the recent government stimulus targeted to hospitals relieve any of the measurable burden to UH?
I can answer that, and that's a great question. And first of all, let me just reiterate, we're very proud and feel, first of all, very committed to our number one tenet of this entire process as it relates to fiscal responsibilities. We didn't want to have anybody lose their jobs at all. That's compared to many of our colleagues around the country. We did, as we reported in the papers, have furloughs of up to 20%, 1 day a week for some of our workers in the non-clinical area. The question was, how long will that last? I think that right now we're planning 2 months, and it's gonna be reevaluated every month going forward, and to see if our mitigation strategies are enough to, if you will, relieve us of the fairly large financial implications. So the second question was the government money through the CARES Act substantial? Yes, it was substantial, but unfortunately it was nowhere even near the amount of dollars and revenue that's been lost throughout this process. So we're certainly anxious to hear about CARES Act 2 and CARES Act 3.5 and FEMA recovery, and that will certainly help, but it doesn't cover or even come close to mitigating completely the drop in revenue. And let me just say one other thing. There's a drop in revenue because we've gone down to what, Dan? In some cases, only 20% of our activity because we've been forced not to have that activity. The second thing is I can attest to you right now, we're spending close to $75 million in buying COVID-related equipment to get us ready for a surge that actually, thank goodness, thank God, didn't happen. So we have spent close to $75 million getting respirators, ECMO machines, masks, and we have them. But remember, we were supposed to have 5,100 COVID patients. As Dr. Simon mentioned, we have 62. But nevertheless, we got that stuff. So we're going to try to see what FEMA will allow us to reimburse us for us preparing for this national emergency. I think it's too soon to answer the question, how long will the furloughs in that group, who are very important people, we can't do it without them, but how long will that last? I think we just need to see how this goes. And more importantly, how confident we can have our patients be and how confident our patients will be with us when Governor DeWine allows us to start expanding our service offerings.
I think that was perfect, Cliff. Great.
Before we move on, we're talking about masking a minute ago. So why don't we get back to that? Because everybody seems to have this vision of what the new norm is going to look like. Perhaps kids going back to school with masks. It's a new day for sure. Can you help our guests visualize how these masks work and why they are so important?
Sure. So I think if we could put up, Kim, if you could put up the slide about masks, there are a lot of misconceptions about masks. And working with Dr. David Rosenberg, I think, he has presented this construct, which I'd like to share with all of our friends and supporters. It's really important to emphasize that the value of a mask is really in protecting yourself. On the left-hand panel of this slide, you see viral droplet particles coming at somebody wearing a mask. And if you wear a cloth mask, you block about 65+% of those particles. And it's almost as good as a surgical isolation mask that blocks about 75%. Of course, an N95 mask, the one that healthcare workers wear when they're taking care of COVID-positive patients, has a respirator function in the sense that it's completely sealed, and that blocks nearly 99% of those particles. However, if you think about protecting others, in other words, you're wearing a mask and you have a cough and you sneeze and you're sending droplet particles out, the only mask that really provides significant protection to others is actually an N95. And so what this tells you is that you wear a mask to protect yourself for the most part, but it also means then that everybody needs to wear a mask. This is where universal masking comes into play. And so, for instance, as Dr. Megerian mentioned, when our patients start coming back to the hospital, not just to the hospital, but to the ambulatory center for a mammogram, or to the ambulatory surgery center for a colonoscopy or a minor procedure, everybody's going to wear a mask. When you come to register, we're going to ask you, have you had a fever or an upper respiratory tract infection recently? If the answer is yes, we're not going to take care of you today. We're also going to take your temperature when you come. And if your temperature is greater than 100, we're not going to recommend that you come for your appointment that day. We will also provide people with a mask, although we hope they'll have a cloth mask with them. But we will provide either a cloth mask or, if indicated for certain procedures, we'll provide a surgical isolation mask for patients as well. So this is the basis of universal masking, and I think you're absolutely right, Macy. When our kids go back to school in the fall, everyone's going to have a mask. Teachers, principals, and students. And I think, you know, in a way, since a lot of the do-it-yourselfers have started this path, it's going to be a fashion statement. It's going to tell you a lot about your personality, of what kind of fabric you use. And I think it'll be a great opportunity for younger children to pick whether it's Power Rangers or whatever their favorite action hero is and superhero, because it's going to become part of their uniform in the fall.
And I've seen some really even creative things with home masks. We, as you know, at UH have created, Dan, and you know this, close to 100,000 based on a wonderful donation of fabric from Joanne Fabrics, and then from various folks who are sewing, if you will. But some of the folks have made kind of a dual layer mask, and then there's a slot to put tissue paper in between. And that's not a gimmick. That actually improves the numbers you just had on the home mask. So you make it kind of like a little pouch.
Yes.
And then you change that, and then you wash it and you change it.
Absolutely. There's no question that that's an advance. And then, of course, I think one of our most innovative advances, because we were one of the first health systems in the United States, is the copper infused textile fiber called Cupron. So we talked a little bit about this with Dr. Salata. This is an Israeli technology that figured out a way how to use ultrasound to get copper into fiber, embedded in fiber, that doesn't wash out. And copper has antiviral and antibacterial properties. And as we've mentioned before, Cupron masks in Singapore have been given an elevated status to near N95-like, although not in the United States. But we have 25,000 of those coming. We've already distributed 13,000 to all of our healthcare workers who are not on the front line. So we're not using this to take care of COVID-positive patients, either on the floor or in the intensive care unit. But they are better than a regular cloth mask. And they are washable.
They are washable.
And they're washable an unlimited numbers of times. And so that's really great. We give it to the employees. They can take it home, the healthcare workers and caregivers. They can wash it and come back with it if they're not frontline workers. So technology is improving. And of course, there are certain circumstances, which maybe we can get to later, where face shields also are very, very important.
Angela has a good question that I think can really apply to all of us. But her example is this. She used to babysit her 2 grandkids. That ended, obviously, 4 days a week. So will she be able to do that again eventually? And I think the more important question is, what would that look like? That first time that people are coming together again, Should there be masks all the time? Should there be 6 feet apart in the home? Maybe you could touch on that a little bit.
Well, Macy, that's a complicated question. I think a lot depends on the risk status of the grandmother taking care of the children. So, presumably as a grandmother, likely in the age greater than 65 range, but need to ask the questions about lung disease, heart disease, cancer treatment, or immunosuppression, because that raises the bar a little bit. I think with kids getting after it and potentially going to distance summer camp or going back to school, I think there will be a recommendation that if the grandmother is going to babysit the children, that there's masking. So both the grandmother and the children will be wearing masks. The risk, of course, as we know, is not really to the children who either don't have COVID-19 infections or are having asymptomatic infections, and we'll know that later by antibody testing. But if you think about all the patients that have been in the University Hospital's health system, we've had less than 5 at Rainbow Babies and Children.
Yeah.
So it's not a disease of children, the same way that RSV that affects kids is not
Right.
really a disease of adults. And we don't know why that is, but I do think that that babysitting scenario that you're talking about is going to be a masked situation.
It is, and it's going to be predominantly based on what we know today to protect the grandmother.
Exactly.
Because the children seem to be very, very well suited to not, if you will, succumb to the virus. We have some time to test the antibodies, but we're really not seeing a lot of children get it. But I think, one quick question is, I think the first question that the caller or the asked was, will I get back to babysitting my grandchildren? And the answer is yes, absolutely. We are going to deal with this thing. We're already dealing with this thing, and we're going to make it go away the best we can. And I don't say that because I'm Pollyannish. I say that because, this hospital, this country has dealt with devastating infectious diseases in the past, and with much more severe, if you will, death rates. Dr. Simon was talking about the Stanford, if you will, antibody study. They did some data that actually looked at antibodies and were able to calculate the death rate in this, which is terrible. At any one life is lost. But we're looking at, if you will, mortality rates in the Stanford study overall, once you get the true number of people infected, really at less than 1%. Would you agree?
Oh yeah, in fact, based on their antibody data suggesting that we're off by about 50 to 80 fold on the true number of infections.
Right.
We're hearing numbers of around 0.2%, which is only double, I
The
hate
flu.
to say only, but is
Right.
very close to flu at about 0.1%. So it is going to be something
Yeah.
that's going to allow us to go forward.
But remember when we had SARS or MERS running at 10% death rates, we had AIDS when it first came out was universal. We will get through this. We will get through this. I think the key is going to be very reliable antibody testing first, followed by a vaccine, an effective vaccine. In the meantime, though, we're not going to give up our normal way of life. We're going to figure out a way to get back to it as safe as we can.
Macy, the biggest question that I'm getting is a real practical one. And that is, when can I go back to my barber or my hair salon? And obviously looking at Cliff and me today, you can see that we've been fortunate to have somebody who's been able to cut our hair over the last, since March 8th.
Be honest, though, it was our wife, right?
Well,
So-
I couldn't get my wife to cut mine, but it was close. So
Yeah, I mean, so we don't want them to think we
no, we did not.
jumped the line or anything.
No, we didn't jump the line.
Okay.
But that is a really big question. But I got to tell you, that's one of the highest risk interactions, okay, for a barber or someone who's in a hair salon, because you're in that 6 feet radius for more than 5 minutes. I mean, that's a very big exposure for that barber or hair salon. And their recommendation, in contrast to a cloth mask, is ideally an N95 plus a face shield, because they are going to be exposed for hours and hours of a day with very close contact. Now, there are some who've said that a surgical isolation mask plus a face shield is as good as an N95. But, you're talking about day after day being exposed to, 10 to 20 people that you have no idea what their quarantine status has been and how they're out and about. So I think we will go back to barbers and hair salons, but our barbers and hair salons are going to be decked out in a lot of PPE.
Yeah, well, that begs the question then, realistically, can they get that high level equipment?
Right. I mean, right now, I think we're coming out of a national position where the entire country was planning for a gigantic surge. And all our numbers about whether there's PPE available is based on the assumption that we got to that 350% surge. That didn't happen. So I predict, I can't be, but my prediction is that as we keep going down, we will start having more and more possible surpluses of PPE. On-site manufacturing of N95s are picking up. As you know, both Steris Corporation as well as Battelle have figured out ways of cleaning N95s and other PPE. I do think as we go further, the numbers keep going down and we start having more in United States production, we will have more PPEs for those barbershops, for those restaurants. Again, it's going to take time though.
Okay. Barbara has a question about what she's been reading with patients getting blood clots. Can you speak to that? What does that mean?
Well, this is a very, very challenging area, and I'm glad that she brought it up. So what we are seeing now is both diffuse, meaning in multiple organs, small vessel blood clotting or thrombosis that can affect the heart, the kidneys, and the brain. And I'm sure many of you have heard about something called COVID toes, which is in people who have infection will develop purple toes, which are a sign of small vessel thrombosis in the toes. What we have also seen, though, which is a little more concerning because it can be more life-threatening, is large vessel blood clotting that can cause deep vein thrombosis and pulmonary embolism, which is seen in patients in the intensive care unit, as well as a very disturbing story that came out this weekend of an increased number of large vessel strokes in young people. So people presenting as their presentation with a stroke are having a blood clot causing that. So there have been a lot of experts across the US and across the world who've gotten together to make some recommendations regarding blood thinners or anticoagulants at the time these individuals are hospitalized. The problem is it's sort of a razor's edge balance between clotting and bleeding because these individuals can also bleed. So our patients who are coming in are being assessed by hematologists, and there have been recommendations for adding blood thinners to at-risk individuals. But it's a big problem. And interestingly, although we have all focused on ventilators and the shortage of ventilators in New York City, the #1 equipment shortage now is actually the dialysis machine. Mm-hmm. And that's because of this small vessel thrombosis in the kidney is causing kidney failure and the need for dialysis. And so this is a real problem that's impacting care. And of course, now there's a whole rev up for getting adequate number of dialysis machines for hard-hit areas, especially Boston and New York still.
Yep. Detroit.
Yep, and Detroit.
We touched on vaccine, but a couple of our guests really want to know what the latest is because I think there was a study discussed out of Oxford over the weekend. And there's been some talk about foregoing animal testing and going straight to human testing. Just want to touch in general about vaccines?
Well, vaccines are a tricky area. And so I think, Dr. Fauci has been very clear that a vaccine that's widespread and available to the nearly 6 billion people in the world is something that's a 16+ month process. There is some optimism out of the Jenner group, the Jenner Institute at Oxford, related to a RNA vaccine technology, which importantly has never been the basis of approval of a prior vaccine. So we got to be, realistic. Secondly, as people have pointed out, the vaccine experts, the fastest vaccine ever was the mumps vaccine, which took 4 years. So I think it's possible, Bill Gates has put $3 billion and is betting on 7 different vaccine horses because he doesn't know which one is going to win. He's supporting 7. And there are different technologies. The most common one, I don't know, Kim, if you can put up the first slide of the coronavirus, which is the spike proteins. That's how the virus gets its name. The coronavirus are those spikes on the outside. And you can imagine that you put in an activated version of the virus that has those spikes. The antibodies grab on to those spikes and prevent the virus from being able to enter cells. So that's the leading candidates for vaccines. We've talked about a vaccine out of Israel, which is a poultry coronavirus vaccine, which protects chickens from a coronavirus infection, which has now been adapted to COVID-19. Those are all in early testing, and it's possible, I guess, that we could have a protective vaccine from those trials in 12 months. But then the question is, how do we mass produce it? And interestingly, because it uses fermentation technology, there's been talk of going to beer producers, going to Anheuser-Busch, Miller Coors, and others to take over their fermentation vats to make vaccine, because we're going to need up to 6 billion doses in the world. This is going to be a long process with a lot of starts and stops. There is some evidence that the vaccine is protective in non-human primates, but we've learned, Macy, from some bad vaccine experiences that you can actually make the disease worse with some vaccines. They become more activating. The complications are greater. So I think we're going to have to go through the steps of normal volunteers to then individuals to see if they develop protective antibodies, and then to high-risk individuals to see if they actually have reduced infection.
And I think the other thing that we need to realize is that, and I don't want to rain on the parade, but for example, every year we have a flu shot. That flu shot is essentially a vaccine against a version of the influenza virus that our experts have determined is most likely to hit us. And we know that confers sometimes at best about a 75% success rate, right? And so,
in some years only 30 to 40%.
Exactly. So I don't, we're going to get there, but I think that the notion of it being a home run at the first swing at the pitch, I think we got to be ready to do all the other things that were talked about earlier in this presentation to prepare and protect our communities. I think then we could have a vaccine, but I think it's going to be a little bit.
Well, you mentioned the flu, Dr. Megerian, so I'm going to bring up this question from Donald. Why should we be scared of getting a disease that is 2 or 3 or 5 times more lethal than the flu?
Well, I think that's a good theoretical question, but and let's just look at the numbers. I think last year the flu killed about 22 to 25,000 Americans, and right now we're sitting today with the COVID have killed, unfortunately, 54,000 Americans, so little bit more than double. So I think the question that the caller is bringing up bears some discussion. Why should we be more concerned? Well, number one, we know this is much more highly contagious. In other words, it is 2 to 3 times more contagious than the flu itself. So some of the things that we typically do to stop spreading the flu to our coworkers and our families, this virus blows through that, right? I think that's number one. Number two, it tends to really have a graduated effect in terms of how older folks are affected. Certainly the flu can make older folks sicker, but in terms of the effect this has on folks who have other diseases, this COVID is much more serious and much more lethal than that. And I think those two things are very, very important, why we should be doubling down on this.
The other thing, Macy, which is...
And one last thing I'll say, one last thing. I think what Dan alluded to earlier, Macy, is that the flu, although it is a challenge to have the flu, we've all had the flu. We've had our friends and loved ones have the flu. It typically doesn't come with a host of other horrible side effects like clotting your kidneys or having strokes or having your toes become purple, which means they're going to maybe become gangrenous. So there's some additional bad stuff with this on top of the flu that I think has got all of our attention.
The other thing, Macy, which is very different, is that, one, we have an antiviral to treat flu. So we have Tamiflu. So if you have a patient who has high risk, they have heart failure, because a lot of my patients with heart failure, when they get the flu, it's a problem. What do we do to sort of mitigate that risk? Well, we vaccinate them, but if we don't cover that strain, we give them Tamiflu. So what's missing, the big missing piece in COVID is an antiviral that works. So typically what we're really hoping is that in about 2 to 3 weeks, we're going to have the results of the placebo-controlled randomized remdesivir trial from Gilead, because that's really important. We have this conflicting data. We have an investigator from the University of Chicago who was in the same trial as us, who was overly communicative about her site's experience with the drug in about 125 patients, saying that they were seeing dramatic response rates. And that led to a lot of exuberance about remdesivir. And then last week, the WHO had some results from a trial in China that was stopped early, not because the drug didn't work, but because there were no more COVID patients to enroll in the trial. And so it wasn't powered to find a meaningful result. So then we heard, well, maybe remdesivir isn't working. Well, what we really need, and we've enrolled about 55 patients in that trial, is for the placebo-controlled trial to report its results. And if it reduces the severity of COVID by 50 or 60%, then we're in the position to say, if you get COVID as we open, here's a drug which is like Tamiflu. Now, it's not oral like Tamiflu. You have to take it intravenously. So we got to get around that issue, that it's not as easy. But having a vaccine that's 40 to 70% protected and having Tamiflu is why we're only having 20,000 deaths and not more. So there is a difference.
And I don't want to scare our viewers in that if you had a vaccine, let's say the first version of our vaccine was not 100%, but it if you will, gave protection to 60 or 75%, the remaining folks would probably have, if you will, a muted experience. So we've seen that in other vaccines that aren't 100%, like the flu vaccine. So again, we're very enthusiastic, but I think Dan is right. What UH is doing right now is doing the best it can on two fronts. Number one, it's working, and we're one of the first to have the clinical trial with remdesivir. We want to see what that can bring, if you will, as an analogous drug to Tamiflu. Second, we're using all sorts of other tests to hopefully stop the virus from getting in us with these various things working, the ARM study that we're doing. And then finally, we're not immediately involved with Oxford, but Oxford is our partner, research partner. So we do have some hope that if indeed that progresses, we would be involved with that at the next stage.
Yeah, excuse me, there's no question. The investigators in the Jenner Institute at Oxford are very familiar with the Harrington Discovery Institute. We have a COVID competition with Oxford right now. And believe me, every time we talk to our friends at Oxford, we remind them that we would love to be a US site for the Jenner Institute's vaccine.
There are some questions about when the antibody testing does become widespread and available to people. What criteria do you see that using? And then how would one go about getting that?
Great question, Macy. I would say the following. We are going to prioritize the antibody tests, as we mentioned, to healthcare workers first, second to high-risk individuals, and then third to everybody who had a flu-like illness with a negative flu test that was told you probably have COVID, but we don't have enough PCR viral tests for you. So we need to see, did you actually have COVID? After that, everybody in the United States should have an antibody test. As South Korea has shown, they've tested everybody, their entire population. Singapore, the same. Germany is doing the same thing, and we will get there. The way that it will be done is you will call your primary care physician, and just like you have any other lab test, they'll schedule you for the lab test. It's just you draw blood.
What's a pinprick?
Yeah, or a pinprick or drawing blood, depending on which assay that we use, but it's just a simple blood test. And eventually, it will be available to all Americans.
So let's talk a little bit more about getting back to elective procedures and opening up UH again. And I know you mentioned that you all have been working toward a plan. You're probably not quite there yet. You're developing a playbook for this. but our viewers do want to know what that might look like.
Sure.
Certainly masking, but
Sure. I think anything that first of all, I don't want the viewers not to realize that we're spending just as much time preparing and talking about things that we've talked about in terms of protecting our staff, our patients, and our organization. We're spending that same amount of time with preparing for, if you will, our reentry in terms of our normal clinical activity. So just to go through a possible scenario that we're working on. Number one, we have literally tens of thousands of people who've had tests, procedures that have been halted, if you will, because of the orders, the statewide orders, and those from the CDC. Those right now are all being accessed. They're put in a priority list, and those folks will all be contacted to start coming back and having those procedures with fairly aggressive and thoughtful masking techniques and distancing techniques. The second thing that we are aware of is that there were procedures that were considered essential, and there's procedures that are considered non-essential. And these non-essential procedures can be things like, for example, removal of a gallbladder that, although it's not causing you immediate pain and gangrene, that it's something that needs to come out. Those are examples of what has been called heretofore non-essential procedures. Those procedures are all being categorized, and they're putting in the individual departments are getting ready to start making those connections to bring those people in, again, with all the proper masking and procedures. I think the thing that has not stopped, which people should be aware of, is that essential procedures, our transplants have continued. Our heart surgery for folks who have a very scary, difficult heart situation, those have continued. Trauma obviously has continued. What I think will begin happening is those will continue, but then folks who have various urological, ear, nose, and throat, colonoscopy, radiographic procedures with sometimes interventional biopsies and things like that, that is going to be the first things to open up on top of the essential procedures that are already there. But they will happen within a sphere of safety that we've talked about: distancing, masking, and hopefully soon antibody testing. Why don't you add to that?
Yeah, I mean, I think, Macy, the other thing that's really important, and we mention this again and again, is to understand, imagine University Hospitals Cleveland Medical Center with nearly 1,000 beds. At the peak of this outbreak, we had 2 units of COVID patients, one in Lakeside and one intensive care unit, that were managing about, at the maximum, 30 patients a day. The rest of the hospital, Seidman Cancer Center, Rainbow, Mack House, Lerner Tower, all of our operating rooms, there's no COVID there. Our ambulatory centers, our ambulatory surgery centers, no COVID. So the thing that we want you to know is we are obsessed with disinfection and cleanliness as we move forward. We have been in the entire 90-day period, but moving forward, there will be deep cleaning every morning. There will be surface cleaning every couple of hours, and then deep cleaning every night. And when everybody comes to the hospital, they'll have screening questions, and they'll have temperature taken, and they'll be masked. If you're coming to your doctor's office, we're not going to have you wait in the waiting room. You're going to be in the parking lot. We're going to text you and say, your doctor is ready to see you. You're going to come right into your room. So we're going to change the way that we do this to make sure that this is safe for our patients. Now, this is really, really important because we've been publishing very concerning data that we've talked about before, that patients with real medical problems, heart disease and stroke, someone having a heart attack and someone having an active stroke, is not calling 911 right now. We had an article in the Cleveland Plain Dealer. We have a paper that's under review right now at the Journal of the American College of Cardiology. People are coming in late with heart damage that we can't fix with the stent in the cath lab. They're coming in with a stroke late, and they're not able to get thrombectomy or the clot dissolving drug. So we know that patients with diabetes, heart failure, COPD, cancer screening, every 10,000 mammograms, Cliff has talked about, 30 cancers that we're not detecting. We need to get back to business so that the health of our community doesn't deteriorate. And we're going to prepare our facilities so that we can do that in the safest manner, in the cleanest environment. And we know that our friends and our supporters trust us, our community trusts us, and we're going to live up to that during the recovery period.
Yeah. One thing to add, and I think it's very important, Maisie, and you can hopefully tell by listening to Dan and I that we are complete believers in making this the safest organization for our patients and doing everything we can to inform and prevent problems with the COVID virus. But we don't want to have happen is have the cure be worse than the disease. I was touring the labs the other day on Friday. I mentioned this to Dan, and I was working through the part of the lab which was testing for cancer biopsies. And as you know, cancer has been one of the things that the governor said, hands off, all cancer activities should continue. But meanwhile, our biopsies and our blood samples for cancers have gone down by close to 50%. Shouldn't happen. Our hemoglobin A1C, which is a simple test to monitor how someone's diabetes is being managed, have bottomed out. These are things that shouldn't be happening. And if that continues for a period of time, we've got a whole second wave of a problem, right, with our patients in our community. So we have to work very hard, going back to what I said earlier. If you poll those patients, what do they say? They don't want to come, or they're afraid of coming because, one, they're afraid they're going to get it by either a doctor or someone in the hospital. So we got to fix that. We're going to make them feel better. And two, is your hospital clean? Those are the top two. And so we're going to be doubling down on that to make sure we don't have, the cure be worse than the disease.
Isn't Seidman Cancer Center an example of how things could go? Because in the beginning, we said, we're not going to stop the cancer treatment. We also said, we're not going to let COVID-19 get into Seidman.
That's right.
And we were able to stop that. And those will be the same types
Yes.
of protocol that we will use throughout the system.
That's brilliant. I mean, I think Dr. Simon deserves a tremendous amount of credit, as does Dr. Technos. We knew, for example, that patients who have a cancer need infusions with drugs or infusions with blood products, or sometimes simply fluids. But we also realized that maybe 1 or 2 or maybe 3% of those folks who have known cancers, and I have a family member who's one of those, who comes in once a week for infusions, that we don't want them necessarily sitting next to, on an infusion couch, someone who has COVID, who also needs an infusion. So we created a special hermetically sealed area for those folks who we knew had COVID, but to continue their cancer therapy, right? But that is known cancers. So what we don't want to have is a bunch of cancers go and move up, if you will, the stages that we don't know about. So we need to remind people that we did it at Seidman, like you said, Maisie. We could do it at every other place within our organization.
Okay. So we've got about 2 minutes left. This is an opportunity for you to touch on some things that you want to get out there, I think, as we're beginning to wrap up with our guests.
Sure. Well, let me start, and Cliff can conclude the session. Well, first of all, I want to thank our friends and supporters. Your outpouring, your generosity, and your thoughtfulness has put us in an amazing position with respect to the UH Caregiver Support Fund, as well as the UH COVID Community Response Fund. Protecting our healthcare workers, providing them with nutrition, housing, and other issues related to adapting to taking care of COVID has been very important, and we really appreciate your generosity. The Community Support Fund is having really a transformative effect on new therapies for COVID patients, supporting important clinical trials, and the most important one that Cliff alluded to, ARMS-1, a 5,000 patient randomized crossover trial with an oral spray, an antiviral, to protect our healthcare workers. And that trial is being funded not only by the Cleveland Foundation, but importantly also by university hospitals. A shout out to Dr. Lee Ponsky and Dr. Matahilu and Dan Moore, who in only 3 weeks prototyped a new ventilator that is now producing 500 ventilators a week right here in Cleveland, supported by your generosity and thoughtfulness. We want to thank you for your support. If you want to continue to give, if you haven't given, uhgiving.org. We'll put up that link at the end, uhgiving.org, Community Response Fund, or the COVID Provider Fund. Cliff, you got the last word.
Yeah, I'll be brief. There's nobody I run into now who doesn't either have a personal family member, a friend, a coworker who's been affected by this, directly affected by COVID, and has had either a mild problem all the way up to most severe possible consequences. And we are very, very, both Dan and I are absolutely cognizant of the amount of trauma this has really given to our caregivers, our doctors, our nurses, our respiratory therapists, and those of you in the audience who have maybe not had trauma directly to yourselves, but have had the fear and the change in your life. Simply the change in the way we have to live our lives right now in and of itself is traumatic, it's difficult, and it has consequences. But I hope that you can sense that we are going to do everything within the realm of safety to try to help, if you will, this community start emerging with the good news that we've been ahead of this as the state of Ohio compared to other parts of the country, but we are on the external part as we exit this process. Dr. Simon, myself, and all the other leaders and great doctors are here to make sure that you feel safe and that we double down, and we are very much open to your concerns and suggestions because we want this to help. As I say, every day is one step closer to the end of this process. So thank you.
Thank you.